So hello, everyone. Let me introduce you to a wonderful surgeon by the name of Simon Platt. Simon works for Queensland Health, but is in his own right, has his own surgery business. Simon, just to give you all a little bit of background, about a year ago, I did a silly accident and fell down the stairs and broke my foot. Simon was my surgeon, and Simon did a wonderful job in repairing my foot. And through that process, I got to know a little bit about what Simon does and his expertise and how he wants to develop an app that could be revolutionary. In fact, I would argue it is revolutionary in the space of pain diagnosis or injury and pain diagnosis. And what makes this app really interesting is a couple of features. The first one is that this app already started life as a demo. So Simon, along with 5 of his colleagues from around the world, based in the US and the UK, have put together a demo app that they see as being an app that the consumer and the clinician can use to advance and speed up the diagnosis path. And that's really, really important, but I'm going to let Simon talk a little bit more about why that is important. Second to that is that demo app, other than the fact that it allowed a patient to specify their pain areas or their injury areas, at the moment that app as a demo is somewhat dumb in the sense that it is not a smart app. Simon's goal is really to create an app now that brings in AI and allows many more smarts around the path of diagnosis. And so that's what we are now attempting to build. So Simon invited me into his group, and now there are 6 of us, and we are now building an app that we believe could be revolutionary in the APAC region and specifically in Indonesia because of the remoteness of many of the Indonesian citizens in Indonesia. And this is an app that we believe can be very, very instructive and very, very helpful for the Indonesian population and then expanded to the whole APAC region. So that's a short introduction of Simon. But what I'm going to do is I'm now going to ask Simon to tell us a little bit more about his background and you know his areas of expertise. So Simon, thank you for joining us. Simon, would you like to tell us a little bit about yourself?
Yes, thank you, Richard, for that introduction. So I'm an orthopedic surgeon, and I specialize in foot and ankle surgery. I qualified in medicine in 1993. I graduated, I suppose, into independent practice in 2005 when I became a consultant, and I migrated to Australia in 2016. And some years later, I met Richard, which was rather fortuitous. On the background of this, I've had an interest in research and also in the domains of pain and diagnoses, along with patient outcomes. And it was clear to us that some of the kind of analog research that we did looking at pain mapping yielded quite accurate results in foot and ankle disorders. And the reason for that really is most orthopedic conditions globally, to be honest, will map very well to anatomic location. So orthopedic surgery lends itself to understanding the anatomy and then understanding the pathology. So there's a very high yield there. If you can know how to examine a patient and put your finger on the sore spot, then it's likely that's going to be causing you the trouble. And of course, in a narrow entity, as an organ such as a foot or a hand, there aren't many conditions around certain areas that it can be. Who better, though, than to map the pain than the patient themselves, because they will give you a very accurate representation on their body, either by pressing on their hand or their foot and showing you where that pain is, or as we discovered, if you give them an accurate line drawing and allow them to show you where the pain is, that will map very accurately to location. And that location maps relatively accurately, depending on the condition, to the pathology. So we did some work looking at about 100 patients, and from my point of view, it worked very well. And why did it work well? Well, the reason is that common conditions, mainly forefoot conditions, seem to lend themselves to this mapping process. So when we looked at our data, we found that when patients represented where their pain was, we were able to work out what the diagnosis was. So part of this process is really marrying the patient's mapping with the diagnosis and finding the locus, I suppose, an area at which the patients map that to give you the diagnosis. So in short terms, when a patient draws on a foot, if they have an organic foot and ankle condition that is mechanical in nature and has a pathology based in the foot, it is highly likely that we will be able to attain and achieve a diagnosis of that condition just by looking at the pain map. The upshot of this is that where we have big data involved, what we have is a very accurate map. So we create a really accurate area under that curve, as it were, with a kind of normal distribution. So the more data points you have, the more accurate that becomes, and that standard deviation will narrow about the mean to the point where we can create very accurate data. That's our hypothesis. If we add to that patient demographic, this becomes a more powerful tool because certain conditions are obviously more likely in older populations or younger populations. And this is where I think AI will come into the process, because the AI will remove the bias and give us an unprecedented ability to map what we see on a pain map to what the patients are describing and suffering with. So we approached the team at Liverpool University computer department to help us. We had an analog map. We had the paper version of what we wanted, but what we really wanted to create was a map that the patients could draw on in an app form with pictures of their feet, and that would really give us some vector, that would give us some area under the curve mapped to a specific area on the map that would allow us to collate the data. And then the clinicians can put the back-end data in, such as the diagnosis, demographics, and any other conditions. And that's really where we got to in the development of this process. So we had proof of construct in as much that the research that we did and presented actually showed us very nicely that patients are fairly accurate in mapping their data. Where patients are inaccurate in mapping their data, it may well be that they don't have a mechanical pain problem, and that is very helpful to us in terms of making a decision for surgery, and equally in the chronic pain space, because some pain conditions don't map accurately to anatomic location, but that will give a very good discriminator or be helpful in that domain. And equally, we found that on our limited numbers, albeit 100, the patients were actually remarkably accurate in where they were locating their pain. And that translated very well into condition. And that's about as far as we got for several years until I bumped into Richard. And then we started having a discussion about where this could lead to, particularly with Richard's background in the field of big data and AI, not to mention blockchain. So that's where we're up to now, Richard.
So Simon, we talked about your expertise being in the foot and ankle area. Do you believe this app has greater reach? For example, wrist, hip, spinal. Do you see this app as growing from?
Absolutely. So this app, we have narrowed it down to my field of expertise. I'm a general trained orthopedic surgeon, but subspecialized in foot and ankle, and I've been doing that largely since 2005. However, there's no reason why a similar application would not find a way into the world of wrist and hand surgery, spine surgery. And when we extrapolate further, there's no reason why, with enough data and accurate diagnosis, we couldn't start to diagnose abdominal pain, migraines, pelvic pain. This is not limited to an orthopedic entity. This is an interesting concept because it's never really been explored very well before. But I am very much of the opinion, when we start moving off non-anatomic pain such as wrist and foot pain to more visceral type pain or headache pain, I am fairly sure with accurate data and enough numbers with a back end of AI, we will be able to actually give this thing a very high diagnostic yield. So I'm fairly convinced it will not be contained to or limited by orthopedic surgery. it can find its way out into general surgery and a chronic pain space, and the realm of neurology when we're looking at migraines and headaches. How do we distinguish? Are there red flags on back pain that would lead us to a more sinister diagnosis, particularly headaches? So this concept has a huge amount of overlap and use case scenario on the basis of its, I think, utility more than anything else, and accuracy.
So Simon, I think one really important area, I was going to save this towards the end, but I think we might as well talk about it now. I think one important area that I think you need to focus on or explain to us is the role that data plays in this. How important is that data, and what does that data look like, and how do clinicians and healthcare workers interact with their data, with that data? So mention a little bit about the AI, but certainly in the first instance, what are we looking at from a data perspective?
So sorry about the Zoom there, that's an automatic thing. So the data perspective is fascinating. So there's two aspects to this. The first is the front end loading. So the front end loading from our point of view will be seeing patients with a diagnosis. The diagnosis is largely unknown until the patient comes into a clinic space. So there's a point at which we will make a diagnosis or diagnoses for that patient. So what we need to do is correlate the patient maps with the diagnostic data. So this is absolutely vital. This app will not work unless we give it clean data. And what I mean by that is we need an accurate diagnostician at the back end of this app to marry the data that the patients are giving us to a diagnosis. So that's the first thing we need. The second phase of this is where the app will start to come into its own, is that the app will then, using AI and having enough data sets, be able to predict what the diagnosis is where the patients are giving it the map. So the machine, the app, and the process will learn when we give it the information as to what the likely diagnosis is. But over time, the machine will we don't need the diagnostician, because what will happen is the machine and the app and the process will be sufficiently capable of making that diagnosis. The thing to say also is that we probably do want to start to give it or continue to give it data, because we will drill down further accuracy the more data points we have. But there will come a moment in this development where it will almost become sentient and start to be able to give a diagnosis based on the data it's given. But that will only occur if we can accurately record a diagnosis at the front end. So the more accurate data points we have for a variety of conditions, for a big number of patients, ideally cross-culturally as well, that would be very helpful. So conditions across different populations of people, the more accurate this device will be, or the process will be. So I don't think it's necessarily a device or an app. It's actually just a process of learning. The app is the tool, but actually at some point the app will give us the diagnosis. And the more data it has, the more accurate that is likely to be. So that's the vitality and the importance of data.
And I might add one more point, Simon, is at the end of the day, this app is going to, its output is diagnoses. And that's fundamentally what this app is going to output. I think one really important point to add to this is that those diagnoses or reports or whatever we choose them to be, whether they be in-app reports or app or reports that could be externalized, all of that information and diagnosis will be in a format that's readily accessible to other systems. So for example, a couple of formats we're looking at is HL7 and FHIR, because we know then that those diagnoses can be sucked into other third-party systems, and therefore this app actually coexists with other healthcare systems rather than be isolated from other healthcare systems. And that's a really important point. So
I was just going to say, integrating this, I mean, this is interesting because integrating this into an architecture is fascinating, because what will happen is, if you're a general practitioner, for instance, you have a patient who's got a subspecialist condition, so foot and ankle. So normally, say in Australia or the UK, you would refer that to a specialist. What might happen is, if you're a generalist, it might actually suggest to you the imaging modality required to confirm the diagnosis, and the first line of treatment, which may not be referred to a specialist, but referred to a physiotherapist or an alternate treatment pathway. So there's a huge, let alone the app having what's the right word, an economic impact in itself. The knock-on effect, the consequence of this app has huge economic consequence as well, because it may put the patient in the right place a lot quicker and a lot more cost effectively than this, even in standard healthcare processes that we see now.
So Simon, at this point, could you possibly give us a presentation, a typical presentation that you have given your other colleagues and associates around, you know, why this app? Why is this app important, and what is the benefits of this app from your particular expertise?
So I have a presentation that we presented internationally in 2014. I'm going to share my screen, and this really, it doesn't set out the app per se, but what it does set out is the foundation for the app. So it's the pretext of the app, and the app merely is the electronic version that's far more accurate in terms of architecture and vector mapping compared to what we see now. So I'm going to share my screen. Sorry, bear with me. I'm going to share my screen, and then I'm going to do this, and then I'm not sure, Richard, you'll have to tell me if you can see that.
Yes, I can see that. Yes, I can see that.
Perfect.
Please continue.
So this is our presentation that really sets out the basic research and the fundamentals of what we hypothesize. So the hypothesis is that in any orthopedic entity, as I said before, the anatomic area closely predicts the pathology. So where you have pain in an appendage, a hand or a foot, or even the spine or an elbow, there's a limited number of conditions that's possible, that are possible in that particular area, but equally that maps well to patients and clinicians putting a finger. So palpation into that area is a very accurate guide as to what the pathology would be. So we wanted to see if we mapped foot and ankle pain. So it gave the patients the ability to draw and show us where the pain was. Can we actually predict the diagnosis? Can it help in treatment planning? And also, ultimately, this is a prognosticator. So there is prognostic implication for this. So we prospectively studied patients. So we have patients coming into our foot and ankle clinic. These are not trauma patients. These are patients with chronic or nearly chronic conditions presenting to our service. And we looked at 104 new patients over time. And we'll come on to how we got the pain mapping pro forma and what it looks like. But basically, all patients were presented with the pain map and showed how to fill it out. So the nursing staff were very helpful because they helped the patients. They didn't prompt the patients or guide the patients. They just told them basically how that might, how you're going to draw on this foot to show the doctor what might be the concern. And then we analyzed our data. So we did, so the hypothesis was that, this would be, or the research question is, can we accurately map pain to condition? And then the analysis and the results will come to. We looked at outcome measures such as demographics, pain location, pain type, where the pain was, like weight bearing and pain at night. And we also provided them a visual analog scale, which is a standard pain score, so 10 centimeter visual analog scale, and the patient would mark on that score where their pain was. So this is, excuse me, our pro forma, which is paper pro forma back in 2014. So we put the patient's demographics, and then we asked them to indicate, we gave them a selection of inks, and they could use anything they liked, or a combination of red, black, blue, or green. So did you have stabbing pain, burning pain, numbness, dull or aching pain? And you really carte blanche for the patients to really show us what that pain was like. Very hard sometimes to get the quality of pain, but most patients will have some kind of estimate. And then we asked them if they had pain on weight bearing and pain at nighttime, and then down the bottom of that pro forma is the VAS score, so 10 centimeter score, so they give us the severity of pain. And this is our pro forma. These are pictures of feet, obviously. They're not line drawings. They were as accurate and as bland as we could make them, as standard views of pain on the bottom of the foot, top of the foot, side of the foot, and a more oblique view of each foot, so right and left, even though the one at the top has been reported twice as right. And then what we basically did, we looked at pain location. So we'll come back to that a little bit, but we interpreted the diagnosis and we gave them a 1 to 4 score, which is a very basic eyeball, very subjective score, where we thought they mapped their pain to. And I'll show you some pictures in a bit of what that would look like. But 1 was localized to predicted area, pain beyond pathological area, but within accepted proximity, so close to the area of interest, given the fact we knew the diagnosis. Pain in a discrete location elsewhere. So patients have drawn some pain that was relatively discrete. It wasn't a kind of global pain, but we had no disorder in that area, so that was anomalous to us. And then a more diffuse pain. So patients with more chronic type of pain that was more diffuse. So what do our results look like? So we completed 97 data sets. And the demographics are fairly standard for our clinics. So 64 females compared to males. So the propensity of foot pain seems to be more forefoot in females. Median age 55 years, 15 to 91. So a wide range of ages there. But again, as anticipated, 53% forefoot disorders, and that's what we commonly see. 26% show pathology around the ankle. 89%, so most of our patients would have weight-bearing pain, and interestingly, 2/3 had night pain. So that's quite an interesting finding in itself. And this is the spread of conditions, and I'll move my mouse here. When we look at forefoot conditions, these take up most, if not all, of that kind of vast majority, that 50%. So hallux valgus pain was 20%, osteoarthritis of the big toe was 13%, lesser toe conditions and Morton's neuroma give us another 20%. And then we saw a large tranche of patients with pain around the ankle joint, with no specific diagnosis as yet. And then we looked at the night and rest pain versus the 100mm visual analog score, and we found various conditions. So if we look, say, at diffuse pain, they're right up there with this kind of weight-bearing pain and VAS, but no specific score. If we come to hallux valgus, less likely to have night pain, but more likely to have a weight-bearing pain. So a bit of a jumbled graph, but really it doesn't correlate that well apart from these diffuse patients, but we see some semblance of trending towards night pain and, weight-bearing pain and visual analog score pain. And then we looked at pain localization. So we come back to that. 1 is very accurate. 2 is that slightly not off center, as it were, of the location. That's very much subjective by a centimeter or so. 3 was that you've got discrete pain elsewhere, but removed from the area of interest. And 4 is that diffuse pain. But from our point of view, when we look at the forefoot disorders, such as hallux valgus, hallux rigidus, or lesser toe, and Morton's, what we're seeing is very high domains up in the 1s and 2s. So we're very accurately already seeing these maps coming through relatively quickly in our data set of only 97 return questionnaires that say, actually, this maps very well. If you've got a bunion, it's pretty accurate to your diagnosis, because most patients will sit between this 1 and this 2. And the same for big toe arthritis, mapping very accurately. Lesser toes and Morton's neuroma, and interestingly also ankle joint and our peroneal tendon pain, obviously, again, fairly accurate. So what this graph really shows visually is that we are mapping well to an expected pathology. Pain localization to pain severity, and again, this is interesting when we look at our forefoot conditions. So here we go again. Hallux valgus and visual analog score map very nicely. So when we look at these mapping conditions, hallux rigidus, again, we're seeing that forefoot conditions actually are fairly well correlated to the severity of your score and also how well you map. So that gives us good triangulation. What it's telling us is that where we see an accurate pain map and a VAS score, those two things with the appropriate diagnosis are actually mapping very well together. And that would be kind of confirms our hypothesis. We look at the pain type, and again, this is a very, very subjective review by patients. But when we look at our forefoot pain, again, sharp stabbing pain versus an ache are really predominant in those hallux valgus, hallux rigidus. So we're seeing, again, in the forefoot conditions, the Morton's neuroma, pretty good here at predicting this as a sharp stabbing pain. Whereas the burning sensations, the numbness, the more neuropathic elements are not coming to the fore in these very mechanical conditions. So again, this is nice data because it shows us that not only is the pain mapping well to location and by severity, also by type. So we've got this very nice triangulation of our data here. Neuropathic pain, again, this is interesting. We've got a nice range of neuropathic pain, unexplainable by us, apart from the fact there is no doubt that in chronicity of pain, chronicity of foot and ankle conditions, there is likely to be an element of neuropathic pain. But if you look right here to the right, again, you've got this outlying group of that diffuse pain. So the diffuse pain tells us that this doesn't map accurately to any organic or mechanical diagnosis, but 100% of the diffuse pain group had neuropathic pain. So those patients are almost or automatically discriminating out from the mechanical pain group by the very fact that they don't map to pathology, but they seem to be hitting very high scores in neuropathic pain. So again, there's a kind of interest here in the pain space, or the chronic or complex pain space, because we can identify some patients who probably would not benefit from any intervention other than a pain intervention, because surgery is unlikely to make them better if they don't have a mechanical condition. But of course, we understand and we're aware that there are overlap in these groups. So what did we find? So moderate to severe pain in our foot patients were in 92% of our disorders. And so really just over 4/5 of our patients map pain to where we expect it to be. So that's very accurate yield already in only 97 patients on a paper-based system. Forefoot disorders localize pain best. And again, that may be an anonymous result based on the numbers that we saw. So the more numbers we collect actually might just settle itself down into all patients mapping accurately. 1/5 of our patients map pain unexpectedly. So there's something about those patients that doesn't map well or correlate well to mechanical pain. And that's of great interest to orthopedic surgeons and pain specialists, because we may be able to identify patients who may not need surgery, but another modality of treatment because they don't have mechanical issues or partial mechanical issues, but maybe there's something else going on. We found that a higher pain score was correlated well with a good localization of pain. And most of our pathologies are mechanical, so they suffered with sharp and aching pain rather than neuropathic pain. We didn't see much of a correlation between pain type and pathology, and we had this non-recognizable pattern. We couldn't explain the unrecognizable pattern of neuropathic pain that seems to have there's a prevalence of that neuropathic pain in our population. And again, that's quite an interesting finding because we weren't expecting that. So on our very limited first go at testing our hypothesis, we're fairly confident that it was a useful tool because we can actually discriminate between a likely win for surgery with a mechanical condition and a likely this is not a mechanical condition. We can use this kind of mapping in correlation and conjunction with patient-reported outcomes to objectify symptom improvement and how things improve, or see other changes in the foot, so pain elsewhere as a consequence of rearranging the forefoot mechanic. And most importantly, I genuinely think this is a useful diagnostic aid. So if the patient cannot accurately describe location of pain, the more data sets we have and the more data we correlate and use wisely, I'm fairly certain we'll be able to look at the patient's data set and say this is a mechanical condition likely to be this, or this is a non-mechanical condition and sits more in a complex kind of pain space or a chronic pain condition. So those are pretty bold assumptions from our data, but we found even with limited data that our data was actually fairly accurate, particularly in forefoot conditions. Why was that? Well, it's anatomic location. And the other thing is, of course, 53% of our patients suffered with forefoot disorders. So there were higher numbers in that group as well, which yielded kind of, you can extrapolate that the higher numbers is likely to give you a better result because more patients are mapping their data. So that was our conclusion. So that was back in 2014 when we carried out that study, and subsequently developed an app that actually gives us very nice line drawings and the patient's ability to draw on the app where their pain is, and that's collected as an area. So we got vector mapping underneath that, that will give us an area or a volume of where those patients are mapping their pain data. Thank you.
So, Simon, I think there's two really interesting comments that we can make to end this presentation. The first one, I think, maybe if you'd like to just mention the fact that you're using patient-reported outcome measures or PROMs, and what you see, why is that such a powerful tool?
So patient-reported outcome measure is a very powerful tool for us as orthopedic surgeons and clinicians, because we have moved away from what the clinician thinks is important to what the patients are reporting. So we're informing our practice based on outcomes from the patients that are likely of relevance to them. So in orthopedic surgery, instead of looking at x-rays thinking we've done a good job, actually we're very interested to know what how the patients are responding to treatment. So for most of our patients, we use an EQ5D and a MOX-FQ, so Manchester Oxford questionnaire. The EQ5D is a 5-questionnaire generalized health questionnaire used with a visual analog score. I also collect data on a catastrophizing scale for my patients as outcome, because we know, and we've done some work and published on this, several papers now, that chronic pain conditions, even with mechanical basis, the patients are likely to score highly on catastrophizing scores. So what's interesting to us is seeing how patients respond to a treatment over time in their promised scores, which is very interesting, and also the rate of change. So when I see a patient who's got a condition, we have enough data to actually be able to say that patient, to tell that patient, your scores are likely to normalize within X months given this condition. So the average data conversion from abnormal MOX-FQ to normal MOX-FQ and your health indices will start to improve at 3 to 5 months. So up until 4 months, we know where you're going to be. But if you're outlying from your 5 to 6 month mark, we need to be concerned. But we'll just follow, and we'll follow the trajectory of your recovery. The power of that data, though, in combination with a app that records visual data, which turns into volumetric data, becomes very powerful, because we'll see a visual representation of diminution of pain, which is very interesting to us. And the other thing we'll see is whether pain occurs at other points in the foot and when, following an intervention. So PROM scores are vital to yield population data and response to treatment for us, and will also give us an underlying barometer, really, of what patients with chronic pain conditions and chronic and complex foot conditions, where they're sitting. So what's the average or the mean MOX-FQ for someone with a bunion? Do we know what that is compared to the normal population in our population? And it lets us map and predict the effects of treatment to a very precise level in terms of temporal recovery. So very important that we collect PROMs data as well.
And maybe, Simon, if I can end this with one really, I think, fascinating extension of this, and that is the possible use of either 3D models or, in fact, virtual reality. In the first instance, we're going to be using 2D maps so that patients can actually draw on these maps as to where they see their pain and where they see their discomfort. But maybe if you want to just make a quick mention of the extension of this and the possibilities around maybe using 3D or virtual reality.
Well, I think there's there's two potential use cases for augmented and virtual reality. The augmented reality model would be that the patient is able to see the pain map on their foot, or you can map the pain very specifically to their own foot. So we're not drawing on an app. What you're actually doing is marking on your own limb where the pain would be. So that's a very accurate map for the patient, because they can hold on to their limb and determine where the pain is. So we're not relying on drawings. We're now relying on the app knowing where the patient's limb is in space, in an augmented reality space or volume. So that would be a huge step forward. And the other thing is the use of intervention. So when we look at pain interventions, of which I'm no particular expert, there's a lot of work being done with, say, for instance, mirrors and movement, where patients are undertaking movements of painful joints, or patients with complex regional pain syndromes, are starting to mobilize their limb in a way that will overcome some of their pain condition. So I see the augmented space where we start to work on developing a recording process can actually move a little bit into a treatment process, both in a complex pain setting and equally in a rehabilitation setting. So we can use the patient's own foot and overlay it to show them what should be done. So the door is very much open with this augmented and virtual reality construct, because this is version 1, but we're looking already towards version 2 and version 3, where we iterate this into a better process, and then we can start to manage treatment and also highly accurate mapping using the patient's own limbs. So that's where I see that going.
So thank you very much, Simon. I think that was
you.
a good synopsis, a great summary of why this app is needed. In the next section of this video, we'll actually introduce you individually to each of the team members. But otherwise, for this particular part of the video, thank you very much, Simon.
Thank you. Thanks very much.